Identity and authentication, suffice it to say that there is a robust set of measures that ONC has developed in conjunction with other organizations, NIST and others, and those are all incorporated through the DURSA for the exchange. There are specifications and protocols, there are technical specifications, there is a certificate of authority, there is a UDDI registry. So the DURSA doesn't create any of that. The DURSA simply codifies that those exist, and the parties, by signing it, become subject to those requirements. And then finally, in the same vein, you have specific technical requirements. So this is how the DURSA crosswalks with the trust framework. Now, let me do some more myth busting here before we open it up to questions. There are those who are concerned that the DURSA is extremely difficult to comply with, that it really does impose upon would-be participants a very burdensome, a very onerous set of requirements that really only very large, sophisticated organizations can ever hope to comply with. And I can understand that perception. I don't believe it's true. And I just categorically don't believe it's true, because when you read the agreement, as I've said, the legal requirement that the DURSA imposes is compliance with HIPAA. Well, every covered entity, from the smallest physician practice to the largest, most complex multi-facility integrated delivery system, every covered entity, whether you're a provider or a payer or a health plan or anyone else, complies with HIPAA. And I've been around long enough to remember that when the privacy and security rules were put into effect, we were all convinced the world was going to end, and that no care could be delivered, and that the healthcare system would grind to a halt. And you know what? There was some reason for concern. It wasn't all crazies who thought that, and it wasn't completely unreasonable to have some concerns about what would really happen when the privacy rules went into effect. Well, guess what? We all survived. The healthcare system did not grind to a halt. Care did go on. Did practices change? Yeah, sure they did. Of course they did. Are we better for it? I think we probably are. But it's understandable that whenever there is something that's new and not, you haven't worn this coat before, it doesn't automatically feel comfortable. So I understand the context for this, but in terms of the facts are that what the DURSA requires is that you comply with the laws that you have to comply with already, be it HIPAA or be it other laws, state, federal, that you're already subject to, and frankly you're already complying with. In addition, you certainly have to comply with the exchange policies, with the technical specifications that have been adopted through the work that ONC has done, and that are being adopted to support the activities of the exchange. I don't believe they're onerous, but that's the fact, and that's my goal here. Another myth, that if your organization is a participant, a capital P participant in the NHIN Exchange, then everyone in your organization has to sign the DURSA. That is a commonly held misperception. The answer is no, that is not correct. If you're Kaiser, Kaiser has signed the DURSA. That does not mean that every contractor, every employee of Kaiser has signed the DURSA. Certainly not true. Med Virginia is an HIE. It is not a provider. It's actually a health information exchange just down the road based in Richmond. It has signed the DURSA as a participant. That does not mean that all of its over 1,000 now physician users and the hospitals that are part of the Med Virginia Exchange Network, they have not signed the DURSA. And we can go on and on. Loveless Clinic, CareSpark, others. So I think it's very important to understand that while organizations that want to be designated as an exchange participant absolutely have to sign the exchange, have to sign the DURSA, as well as meet the other eligibility criteria, that does not mean that all of their participants sign that. It wouldn't even be appropriate for them to. It wasn't designed for them. There are flow downs, however, and that's in quotes because it's a term that we tend to use in association with the federal acquisition regs. It's out there in the field, and so I decided why not go with it, because that's the term that folks have sort of used, and it's an accurate enough construct. There are flow downs, there are provisions, there are places in the DURSA where it says to Kaiser or to Med Virginia or to VA that you must have agreements with the folks within your world, whether it's part of the employment agreement with Kaiser, whether it's part of the participation agreements, the user agreements that Med Virginia has, whether it's through agreements that VA may have with folks within their orbit, both employees, contractors, and others. There are provisions that the participant is obligated to be sure are included in those agreements, and those are what are commonly being referred to as the flow downs. There aren't that many of them, however, and here they are. There's a finite set. The first one is compliance with applicable law. Okay, I suspect that's already in there. I suspect that you'd be hard-pressed to find a data sharing agreement or even an employment agreement or a contract that doesn't have a compliance with applicable law provision already written in there. Reasonable cooperation with the participant related to exchange issues. Again, probably also in most, if not all, agreements. A requirement that the users, the ultimate users, only submit messages through the NHIN Exchange for permitted purposes. Again, I think any type of agreement that any exchange type of organization has with its users is going to have a construct around how do you use this, and what do you use it for, and what do you not use it for. So again, I think that is fairly common and in place now. Use of message content in accordance with the terms and conditions of the DURSA. Well, that may require some amendment, because certainly it did in Med Virginia's case, because when Med Virginia was created several years ago, the NHIN had not been, well, at least we weren't aware that it had been thought of yet. It might have been considered conceptually with an ONC, but certainly Med Virginia had no inkling of where that might go. We're going back now 7, 8 years. And so, yeah, Med Virginia has been required to amend its participant user agreements in order to incorporate this particular requirement. Was not onerous. And so, yeah, that's one that might not have been thought of when your agreements were originally put together. Breach notification, certainly that while HIPAA has had breach language forever, certainly the high-tech breach notification requirements are new for all of us, and all of us who are in this space that are all involved in healthcare data exchange and the transmission of data. We've all had to go back and work on our agreements to be sure that they are high-tech compliant. Refraining from disclosing passwords, again, I think a very basic requirement, one that everyone has incorporated into their privacy and security policies and procedures and protocols already, one that I'm sure is in most employment agreements, either directly or through incorporation by reference, and also in any type of exchange user agreement. And then finally, an agreement that the signatory does submit to the authority of the participant for purposes of disciplinary action. Again, I think you'll see some variant of that in almost every agreement that you come across. It'll look and sound different in different agreements, but the concept is fairly foundational. So these are the flow downs. And I think when you look at them, most people would say, well, okay, that's understandable. Another fiction is that if I'm a participant in the exchange, then all of my users, and we've particularly heard this with respect to rural providers and very small practices, that means that they're all going to have to report their breaches of data to me within 1 hour. Well, we could debate whether that's a good rule or a bad rule, but that is not what the DURSA says. That is not the standard in the DURSA. And I can certainly understand why people would consider that to be an onerous requirement. Again, without getting into the debate about what is the appropriate metric for data breach reporting, I can understand how folks would perceive that to be a challenge. Now, here's the fact that participants, again, capital P participants, the federal agencies, Kaiser, Med Virginia, Regan Streif, others, they are required to report to the coordinating committee within 1 hour of when they become aware of information that leads them to believe that a breach may have occurred. So once Regan Streif or Med Virginia or Kaiser become aware that a breach might have occurred, then yes, they are on the clock. They absolutely are, and they have an hour to notify the committee. That's in there because our federal partners insisted it be in there, and there was some healthy debate about that, about the ability to comply with that. But our federal partners said we have to have this because of the world in which we live, and because of the way that many of the FISMA requirements are operationalized across the federal space. And so the private sector participants said fair enough. And so again, but this does not flow down to every user within a health data exchange. It does not. It is once the participant becomes aware, then they're on the clock. Now, the flow down is what you see in the last part of the slide, that the users, whether it's a physician practice, whether it's a floor nurse, whether it's a health system, whether it's whatever it is, the users are required to report a breach as soon as practicable after they determine it occurs. Now that's very consistent with where HIPAA is, and certainly where high tech is. So that's what the DURSA says about breach reporting. There's been a lot of I think misunderstanding about that. Okay, so I'm going to wrap up now. You know, if you came into today having heard about the DURSA, not quite knowing what it was, maybe you had some of these myths that we talked about. Maybe you've got others that you're going to raise when you send in your questions. I'll welcome those. There might have been a lot of confusion about it. Our goal is to try to, clear away the smoke and just say, look, here's what it is. It's an agreement among folks who want to exchange data using a set of functions that are currently called the NHIN Exchange. That's what the DURSA is, and that's all it is. It is an agreement, and it's a multi-party agreement that was designed to support a trust framework in order to facilitate exchange. So with that, I'm happy to take questions.
Steve, thank you very much. We've worked together for many years, and I always feel my IQ rise as you speak.
Thanks for that.
Seriously, you've shared a lot of information with us, and a lot of folks on the web have provided some questions, but I thought we might start by having Melissa help us interface with the live audience and take some of the first questions from you folks here. Is there anyone who has a question prepared, would like a few more minutes to prepare a question? Please.
Thank you very much for speaking. I'm actually an intern at the Department of Health and Human Services doing outreach to physicians. I'm also a first-year medical student, and I was thinking in this in terms of how do we sell this to physicians, and maybe this is part of the June 26 meeting, so perhaps you could give us a sneak peek at what is the value proposition, or how do we explain HIE and DURSA in clinical language? Thank you.
I think you probably do want to repeat it.
He's talking to me.
Sorry.
I can repeat it.
There you go.
Okay.
There you go.
All right, so the question was, how do we explain the value proposition of NHIN Exchange to physicians, primarily physicians? And that came from an HHS intern who's also a first-year medical student. Congratulations. I think that's awesome.